Good afternoon. Welcome to 2021 NPMF Forum Virtual Congress. We are starting today, and I hope you will enjoy the next 5 days. And I'm going to talk about patent ductus arteriosus. Should we treat or just ignore? So I have no conflict of interest to disclose. When you look at an echo image of a PDA, here you can see a large PDA. So people got three-finger sign. The first finger is a large ductus arteriosus, the middle one is left pulmonary artery, and the third one is right pulmonary artery. So this is how echo image will show up when you are doing echocardiogram, looking at the ductal view on the suprasternal notch. This baby has a huge ductus. And here is the baby. The duct got closed by a PDA device, transcatheter PDA closure, which I'll talk about end of the meeting. So why should we worry about patent ductus arteriosus? I think the ductal shunt, when there is left to right shunt, it can increase pulmonary perfusion, pulmonary blood flow or pulmonary hyperperfusion, but at the expense of systemic hypoperfusion. So the blood is stolen from the systemic circulation through the ductus arteriosus into the lungs. So it depends on the magnitude of the shunt, which is controlled by the ductal size, as well as systemic resistance versus pulmonary vascular resistance, and ability of the myocardium, especially immature myocardium, to adapt to this volume overload through the ductal shunt, and severity of pulmonary overcirculation, which results in increase in support for respiratory support or a PEEP or ventilator support or high oxygen, and the degree of systemic hypoperfusion to the gut, to the kidneys. So there is a spectrum of clinical features in preterm infants from a persistent PDA. So how do you assess the hemodynamically significant PDA? Number one, you can look at the size of the duct by echocardiogram. You can also look at the shunt direction on color flow Doppler, and you can look at the flow pattern with constrictive or not constrictive pattern across the ductus arteriosus. And looking at the pulmonary overcirculation, if we have volume overload on the left ventricle, left atrium is going to be enlarged, left ventricle is going to be enlarged, and the most common thing we use is left atrium to aortic ratio, LAAO ratio, increased left pulmonary artery diastolic velocity, mitral EA ratio is used in some centers. Again, EA ratio refers to peak velocity of blood flow from left ventricle relaxation in early diastole, that's the E wave, to the flow in late diastole due to atrial contraction and flow increases. That's called A wave. So some people use mitral E to A ratio. But most common echo diagnosis parameters are size of the duct and left atrium to aortic ratio. Left ventricular function can be assessed. What about systemic hypoperfusion? So you can Doppler post-ductal aortic in the descending aorta flow pattern, whether there's any reversal of flow or retrograde flow during diastole. And you can also Doppler assess the blood flow in the celiac trunk, superior mesenteric artery, renal artery, anterior cerebral artery, or middle cerebral artery. You can also look at, as a systemic hypoperfusion, what is the input, venous return through this superior vena cava flow, which is difficult to measure. So most people do not use SVC flow when you are talking about diagnosing a hemodynamically significant patent ductus arteriosus. Here is echo. You can see a large PDA with all left to right shunt across the PDA. Anything that's blue is going away from the transducer. Anything coming towards the transducer is this bright orange to red color. And here, if you look at the flow, left to right, flow velocity. And here is the duct that's right to left, where now the flow is going away from the transducer, so it's blue. And the flow from the baseline, the flow is going downwards. That's a right to left shunt. Flow is coming upwards, it's a left to right shunt. So today, I'm focusing only on a left to right shunt through the ductus arteriosus, not a right to left shunt in babies with persistent pulmonary hypertension or hypoxemic respiratory failure. You can also look at volume overload. You look at the apical four-chamber view when you are doing an echocardiogram. You see the right atrium, left atrium, right ventricle, left ventricle. Even by looking at it, you can see as soon as you put the transducer, left ventricle and left atrium is huge. due to volume overload from the shunt. You can also look at mitral regurgitation because of that. And if you look at the pulmonary veins, here is the right upper pulmonary vein, right lower pulmonary vein, left upper and left lower pulmonary vein. You can see they are huge, they're dilated because a lot of blood is coming back to the left atrium. And because of the volume overload to the left side, you can see the left atrium is huge here compared to the aortic size. So left atrium to aortic ratio, LA aortic ratio is clearly more than 2 in this baby. So these are some of the echo parameters you use to make a diagnosis of hemodynamically significant PDA. You can also look at the flow pattern. What about systemic hypoperfusion? Looking at the flow in the descending aorta. So here is the forward flow during diastole, but in a baby with hemodynamically significant PDA, the flow is reversed. There is return of flow, retrograde flow in the descending aorta during diastole. So people call it as a ductal steal. When steal happens, you also have decreased blood flow to the kidneys and to the gut. And that is why in a baby with hemodynamically significant PDA, there's an increased risk for necrotizing enterocolitis from ischemia to the gut, as well as acute renal failure due to decreased blood flow to the kidneys. So here is one study that we published recently in 2019 with Dr. Shahab Noori from our place, where we looked at PDA diameter and LA aortic ratio. When the ductal diameter is more than 2 millimeters or left atrium to aortic ratio more than 1.4 was associated with a greater risk of abnormal blood flow in the SMA and the renal artery. When both were present, the odds of abnormal blood flow significantly increased. So ductal size and LA aortic ratio plus Doppler assessment of the SMA and renal artery are useful to define hemodynamically significant PDA. We still don't have a consistent definition of what constitutes a hemodynamically significant PDA. So I'm showing all the recent studies looking at this issue. There's also a correlation between ductal size and QPQS, pulmonary to systemic blood flow ratio. Normally, it's 1:1. But in babies even with minimal atrial shunt, small PFO or normal PFO, if the ductal diameter is more than 1.5 millimeters, you can estimate that QPQS is already 1.5 to 2, 1.5 to 1. And the ductal diameter is more than 2, QP to QS, pulmonary to systemic blood flow, is more than 2 to 1. That is why everybody is concerned that when the ductal diameter is more than 1.5, the babies will have 1.5 times more blood going into the lung compared to the systemic circulation. So here is another definition that was presented at the second International PDA Symposium last year by Carl Beckers from Ohio, Nationwide Children's Hospital. They classified duct into 3 categories: mild PDA, moderate PDA, and large PDA. Mild PDA's babies are on a CPAP or NIPPV and the FiO2 is less than 30% or can be on nasal cannula. And look at the PDA diameter, it's less than 1.5, they call mild, not significant PDA, or left atrium to aortic ratio less than 1.5, or left ventricular output less than 250 ml per kilo per minute. When the ductal diameter is equal to or greater than 1.5, or LA aortic ratio equal to greater than 1.5, and the left ventricular output is more than 250 to 430 ml per kilo per minute, and the FiO2 requirement clinically is more than between 30 to 50%, or 0.3 to 0.5, they call moderate PDA. And the large PDA is when the babies are intubated or the FiO2 is 0.5 or greater, and the now ductal diameter is more than 3, and L left ventricular outflow more than 430 ml per kilo per minute. You already have reversed and diastolic flow, both in the moderate or large PDA. So these are some of the definitions they use, their clinical criteria and echocardiographic criteria to decide when they would treat their baby with a hemodynamically significant PDA. It is another paper, a group from Atlanta, Dr. Hamrick et al., Shannon Hamrick, published this paper in November of last year, looking at lower risk, what are the factors, and high risk. So the baby has tachycardia, baby has tachypnea, or babies on a respiratory support that requires worsening respiratory failure, increased need for mean airway pressure, peak inspiratory pressure, or frequent desaturations, abnormal signs and symptoms, for example, abdominal distension, feeding intolerance, the other pre-necrotizing enterocolitis signs, organ dysfunction, renal failure, frank necrotizing enterocolitis, using a near-infrared spectroscopy. The NIRS data is below the expected range. And then, of course, using echocardiography. Again, they use equal to or greater than 1.4 on the parasternal long axis view, LV dysfunction, LV dilation, ductal diameter equal to or greater than 2 to 3 millimeters. So these are some of the criteria they suggest as a baby that may have a hemodynamically significant PDA if you decide to treat this baby. So why is that? After all these years, over 35, 40 years of treatment of PDA, the prophylactic treatment, early rescue, delayed treatment, prophylactic surgical ligation, why is that we have not seen any effect on meaningful long-term outcomes like neurodevelopmental outcome or even BPD short-term outcomes, cerebral palsy? Number one, these studies, there is no consensus on the definition of what is a hemodynamically significant PDA. High rates of spontaneous closure, even in extremely low birth weight babies, with or without treatment, it closes spontaneously by day 3 or by day 7. Younger the gestational age, takes longer for the PDA to close without treatment, and lack of true control. As many babies that were randomized in these trials, actually the placebo arm also received open label treatment of the drug or intervention. Lack of equipoise. Many eligible babies are not randomized as physicians' perception that those babies are really sick and I don't want to enroll this baby in this study, I'm going to treat this baby. So you basically exclude the highest risk babies in these randomized controlled trial because lack of equipoise. And recent trend towards no treatment, no matter how big the duct is. Let's look at the rate of spontaneous closure in preterm babies. This is systematic review published in September 2020. 99 studies, 29,000 plus babies were in the systematic review, and then they looked at different gestational age. If you look at babies less than 28 weeks or less than 1,000 grams, look at the spontaneous closure of the duct without any treatment. By day of life 3, is 34% closed. 1/3 of the babies closed. By day of life 7, 41% closed. So if you treat prophylactically, you're unnecessarily exposing these babies to your treatment regimen and to the side effects of the medications that we don't know yet, long-term side effects of some of the medications like Tylenol. So if you look at spontaneous closure of PDA without treatment happens a lot. In 26 to 27 week gestation, 54% of the babies close without treatment. And in micro preemies, 25 weeks, about 1/4, 26% of the babies close spontaneously without treatment. This data is from PDA Tolerate Trial by Ron Kleiman, which I'll show you in a minute. So you can see spontaneous closure rate in preterm babies occurs more often than we think it happens. Here is another paper from 2017, Sambrov et al., looking at prevalence of PDA stratified by birth weight over time. These are managed truly conservatively. They never got any treatment. And they showed that spontaneous closure before hospital discharge occurred in 76% of the babies, less than 750 grams. However, 50% of the babies, this is the 750 grams, this is 750 to 999, this is the PDA prevalence, this is ductal closure day, arterial PDA closure days. You can see in babies between 1250 to 1500 grams, 50% of the duct closes by about day 7 or day 8. And majority of them close by 2 months or 3 months before hospital discharge. But if you look at the babies less than 750 grams, 50% the PDA may stay open for longer than 50 days. You can see that. So is this okay to expose these micropremies who are weighing less than 750 grams for prolonged ductal shunt for 2 months or longer. They also looked at based on gestational age in these babies. Again, no treatment. What happens to this duct? You can see in babies over 30 weeks, very similar to bigger babies, they close, majority of them close early. Spontaneous closure happened in 68% of the babies, less than 26 week gestation. However, 50% of the babies, the duct stayed open for 75 days or longer. That's almost 3 months, 2.5 months, sorry. Is this okay to leave this micropremies less than 26 gestation with a huge duct and a left to right shunt for so long, whether it will increase the risk for BPD, pulmonary hypertension, or left ventricular failure? Let's look at the data. Again, what happens now that many people are saying, oh, we don't have to treat the duct? So here is some data from Ohio. So the treatment between 2008-2016, over 8-year period, treatment of PDA, medical treatment, dropped from about over 50% to around 10%. PDA ligations, 40 or 45% of the babies were ligated in 2008. Now less than 10% of the babies get ligated in 2016. Similarly, mortality was lower and BPD was lower. Necrotic enterocolitis was lower, the triangles. And severe IVH was also lower. So in spite of not aggressively treating the babies for a PDA, they showed a decrease in mortality, decrease in BPD, decrease in IVH, severe IVH, and necrotic enterocolitis. So the keeping the duct open, otherwise relatively stable hemodynamically, may not be a bad idea. So here is Dr. Meera Shankar and Bill Bennett from Stanford, published in 2019. They looked at 55 trials, nearly 5,722 babies, and they looked at the outcomes. The only thing they found positive, two things were ductal patency was less. If you treat, ductus became smaller. But look at the other outcomes: death, BPD, death or BPD, oxygen at 28 days or at 36 weeks, necrotic enterocolitis, spontaneous intestinal perforation, sepsis, late onset, IVH, except for IVH grade 2, greater than grade 2 was less if you treat the babies, PVL. Even though IVH grade was less, if you look at the outcomes of cerebral palsy, neurosensory impairment, severe developmental delay, death or neurosensory impairment, none of them were different in these studies. So treating a duct did not make a difference in the long-term meaningful outcomes, not even short-term benefits like BPD, NEC, or sepsis. Why is that? A lot of these babies assigned to control arm also got treatment, open label treatment. So they looked at the impact of open label treatment. Again, point estimates did not shift to the left, suggesting that open label treatment in about 6,000 babies they had reviewed, open label treatment had no impact on the other long-term outcomes like neurosensory impairment, cerebral palsy. When the open treatment is less than 50% or less than 33%, it didn't make any difference in making the long-term outcomes better. They also looked at, based on the timing of intervention, whether treatment was given in the first day, prophylactic treatment, or early rescue within 1 to 7 days, or PDA treatment was given between 7 to 21 days. Again, no difference in any of the outcomes. Only thing was IVH grade 2 or greater was less if the baby was treated early in the first day prophylactic treatment. Again, no difference in the long-term outcome like CP, neurosensory impairment. So open treatment happened in all three groups. It is therefore not plausible that exposure to hemodynamic effects of PDA were equivalent in the treatment arm and the control arm. Let's look at a study where this is a randomized control trial just published last year from Seoul, South Korea by Sung et al. 146 preterm babies, the no intervention, no treatment versus oral ibuprofen, oral PO treatment for a hemodynamically significant PDA. They're defined as a PDA greater than 1.5 millimeters in diameter, and the babies were getting respiratory support. So they have to have both. And they looked at 23, 26 weeks and 27 to 36 weeks. No difference in the cumulative incidence of PDA closure. This non-intervention showed non-inferiority compared with ibuprofen treatment in closing the hemodynamically significant PDA, or no difference in this is 23, 27 weeks is orange. This is 27 to 36 weeks babies. Death or BPD was not different. BPD alone was not different. Death alone was not different. So non-intervention, no treatment was as good as treating with oral ibuprofen. And they concluded that maybe because the low efficacy of oral ibuprofen for closing PDA, especially in babies born at 23 to 20 gestation, might have contributed to lack of improvement in the outcomes. Spontaneous closure of the PDA happened in 89% and 82% at hospital discharge in the treatment group versus no treatment group. So both groups, whether the babies are exposed to oral ibuprofen or not, over 80% of the babies, the duct closed at between 23 and 30 week gestation. Let's look at a targeted treatment. This is by Don Kleiman from San Francisco, a multi-center trial, PDA Tolerate trial. Tolerate stands for to leave it alone or respond and treat early. Of moderate to large PDA at 1 week of age in babies less than 28 weeks, that is 24, 25, 26, 27 gestational weeks. Very sick babies, 202 babies. How did they define moderate to large PDA? A PDA diameter more than or equal to 1.5 millimeters, or PDA to left pulmonary artery diameter more than or greater than 0.5, and one or more of the following criteria. 4 criteria. So left atrium to aortic root ratio greater than or equal to 1.6. Ductal flow velocity less than or equal to 2.5 meters per second, because large duct velocity goes down. Mean pressure gradient across the ductus less than or equal to 8 millimeters of mercury. Left pulmonary artery diastolic flow velocity, because a lot of blood going through the left pulmonary artery through the duct. So that's greater than 0.2 meters per second, or reversed end diastolic flow in the descending aorta, ductal steal. So any one of the 4 criteria plus ductal diameter greater than 1.5 millimeters. That was the diagnosis of hemodynamically significant PDA. What happened in the trial? In preterm babies less than 28 weeks, early routine treatment did not reduce PDA ligations or the presence of a PDA at the time of discharge, and did not improve any of the pre-specified secondary outcomes like BPD, NEC, ROP. And on top of that, delayed full feeding because the babies were all given indomethacin or ibuprofen, so the feeds were held because the duct was big, and had a higher rate of late onset sepsis and death, especially in infants born at or greater than 23 gestational age. So why? So they looked at babies that are born in these centers that agreed to participate but didn't enroll some other babies. Lack of equipoise in the PDA Tolerate trial. So a comparison of eligible babies enrolled in the trial that neonatologists and parents agreed to be enrolled, and babies that were not enrolled because the doctors didn't want to have this baby enrolled in the study, neonatologists, because they thought, oh, this baby is too sick. I don't want this baby to be randomized to placebo, so I'm going to not consent this parents. I'm going to treat the baby because I think this baby needs to be treated. So they looked at comparing these babies that were enrolled in the Tolerate trial versus not enrolled. That's 137 babies. So gestational age, younger by about 0.3 weeks, 25.8 versus 25.5. Delivery room intubation happened 69% in these babies that were in the study, compared to 85% that were not in the study but were treated by the doctors. 96% of the babies got surfactant. So these are sicker babies, and therefore the neonatologist did not want this baby to be enrolled in the trial. Aged PDA treatment in this Tolerate trial, remember after 6 days only they start treatment after first week, so 8 days on average compared to 5.4 days in the babies that were not in the study. Death, 14% mortality compared to 3%. So even though these are sicker babies, they treated based on the early treatment, the mortality was significantly lower. So when you look at the babies that were not enrolled, that's in these two columns, by the doctors and treated, in that group they said if the treatment was given before 6 days of life, they actually had a higher risk for necrotizing enterocolitis or GI perforation compared to babies that were treated after 6 days, 8%. But death or home oxygen was significantly lower in sicker babies not enrolled in the trial, but they got treated 20% versus 38%, almost half. So despite being less mature, needing more respiratory support, infants eligible but not enrolled because of lack of equipoise had lower rates of mortality than enrolled infants. Infants not enrolled but treated before day 6 had lower rates of respiratory morbidity than infants treated after 6 days of age. So there's a recent paper published 2 months ago, February, looking at secondary analysis of the babies in the Tolerate trial, 146 babies. So they looked at prolonged PDA shunt, persistently large shunt for a long period of time, and respiratory support and association BPD, either mild BPD or BPD grades 2 and 3, severe BPD. So if the babies were extubated by 10 days, that only intubated for 10 days, even with a big PDA shunt, the incidence of BPD did not go up. But if the babies had a big shunt and stay intubated, then they had a significant increase in grade 2 and grade 3 BPD as the days intubated went up beyond 10 days. So this is less than 10 days, 11 to 14 days, 15 to 20 days, or more than 20 days. As you can see, if the baby stays intubated longer and also had a hemodynamically significant PDA, that was the only one associated with severe BPD. Remember, previous trials and studies, observation studies showed that if the duct stays open, you have more mortality or more BPD. That doesn't appear to be true in the current population and current studies. So here is another systematic review of conservative treatment versus active treatment of PDA in preterm babies. They could only find 4 randomized controlled trials involving 420 babies and 12 cohort studies, 41,000 babies. So they looked at relative risk, and 95 confidence intervals are shown here. In all these 4 randomized controlled trials, which are high quality studies, there was no difference in mortality, no difference in BPD, no difference in NEC, no difference in all grades of IVH, and no difference in any grade of retinopathy or prematurity, whether you treated the baby or not, conservatively managed the baby, like fluid restriction, use of diuretics, and so on. In the cohort studies, conservative treatment actually increased the mortality compared to treatment. PPD was lower, NEC was lower, IVH all grades was lower, and ROP also is lower. So no difference in randomized controlled trials in any of the outcomes, but in cohort studies, it showed a decrease. Again, in case controlled cohort studies, the quality of evidence is really low. So we cannot base our treatment based on cohort studies. That's not a good grade evidence. So once you treat a hemodynamically significant PDA, based on whatever criteria, I'm going to show you what recommendations are. What do you treat the drug? What drugs do you use? Do you use paracetamol or Tylenol? Do you use indomethacin or indocin? Do you use ibuprofen? And other issues are, should I give oral or should I give IV? I showed you the data. Oral ibuprofen did not work. And there's systematic review recently, Cochrane review, that showed that ibuprofen for prophylactic treatment of PDA is not recommended. Standard dose or double the dose, as some people have done. What age you should start treatment, and rescuing with another class of drug. In other words, you gave indomethacin or ibuprofen, the duct reopened or didn't close. Can I use Tylenol or paracetamol for a second or third course? These are all some of the issues that are still not sorted out. Here is a Cochrane systematic review published last year, looking at randomized controlled trials using paracetamol or Tylenol in preterm babies or low birth weight babies. They had 8 studies, 916 babies. The conclusions are Tylenol or paracetamol is as effective as ibuprofen, moderate quality evidence. Tylenol or paracetamol is as effective as indomethacin, low quality evidence. So there are currently 19 randomized controls are ongoing to decide which one of these drugs will be better. I think at the present time, they're equally efficacious. Here is a multi-center randomized control trial comparing oral paracetamol versus oral ibuprofen from India. It was published last year. It's a non-inferiority design. 25% of the babies are less than 28 weeks. Mean gestational age was similar, 28.7 weeks. Mean birth weight about 1 kilo. PDA closure after 2 courses of either oral paracetamol or oral ibuprofen were equal, exactly similar, 94 or 95%. That is their primary outcome. PDA closure in babies less than 28 weeks, also equally effective, 94 or 95%. So there is no difference in success rate using oral paracetamol or oral ibuprofen. So they concluded that oral and surgical ligation was not different. So oral paracetamol is non-inferior to oral ibuprofen for the closure of a hemodynamically significant PDA in neonates less than 32 weeks, and no adverse effects were seen between these 2 drugs. So if you do not have IV ibuprofen, if you do not have indomethacin, you could use either oral paracetamol or oral ibuprofen with similar results. Again, only one randomized controlled trial, just published recently, and I told you the data from systematic review. So here is follow-up data. What happened to those babies that were in the PDA Tolerate trial from, this is not from the PDA Tolerate trial. This is a multi-center randomized controlled trial where early targeted treatment of hemodynamically significant PDA. They diagnosed the PDA as a large PDA if this is the formula they used. A large PDA means the size is diameter, ductal diameter is 2.26 or greater minus 0.078 times postnatal age in hours. This is a complicated formula they decided. They used it based on feedback from Nick Evans from Sydney, and they started treatment between 6 to 12 hours of age with IV ibuprofen on survival without cerebral palsy at 2 years of age in preterm babies between 24 to 27 weeks. Unfortunately, or whatever you want to call it, it's a very difficult study. No difference in primary outcome, whether the babies got treated or not. This is placebo. This is ibuprofen group. 114 babies with this large PDA were not treated. 114 babies are randomized and got ibuprofen, intravenous ibuprofen by 12 hours of age. This is a small PDA with a reference group. Again, if you look at the PDA size, 2.28 versus 2.25 compared to the small reference group, small. But the reason why they did not find any difference in outcome may be because look at the open label treatment. Even though babies were randomized to placebo and the doctors are not supposed to use open label treatment, they use 62% of the time. Rescue treatment with ibuprofen was given in this population. And that may be the reason why they didn't find any difference in the primary outcome. Primary outcome is what? Survival without cerebral palsy. Absolutely no different. The placebo group was ibuprofen group. Adjusted risk ratio 0.98. Confidence interval crosses 1. P-value 0.83. I think this lack of difference it's a very good, very difficult study. I should congratulate the investigators from France I think there were 11 centers or so participating in this trial. However, this is the problem, open label treatment in the placebo group. We really don't have a true control group, except the 4 randomized control trials I showed you in the systematic review that showed no difference in outcome if you truly didn't treat a baby. So what is the future? Where do we go? So we know that surgical ligation of PDA causes post-surgical ligation syndrome with cardiac dysfunction, myocardial dysfunction, ARDS like X-ray, increased need for respiratory support, anesthesia, and other complications like vocal cord paresis. So now the trend is more and more centers in the US and outside the United States are using transcatheter PDA closure using an occluder. It's approved by FDA. So here is the report from Memphis, Tennessee, where transcatheter was surgical closure of hemodynamically significant PDA. They have done 134 very low birth weight babies as of 2018. 54 babies were less than 1 kilo. The smallest baby they placed TCPC, transcatheter PDA closure, was 640 grams at the time of the procedure. Median gestational age 25 weeks, and they concluded that it's safe and effective. You can see in their unit, which is a referral unit, they get babies from 10 different hospitals, and even as far as 300 miles away. Surgical ligation dropped close to zero, and TCPC went up. Nearly 50% of the babies are PDAs treated if it's met the criteria for treatment by TCPC. So here is the paper. They concluded TCPC, transcatheter PDA closure, is safe and feasible in babies as small as 640 grams, and it may offer faster weaning of respiratory support compared to ligation when done earlier in life before the onset of elevated pulmonary artery pressure. So they looked at the outcomes, respiratory severity score with the TCPC before, and then immediately after that, they decreased. Percentage change was much more in respiratory severity score, no increase. And time taken to the pre-procedure is 8 hours. Time to extubation 14 days versus surgical ligation 26 days it took. So here again, the babies that procedure weight anywhere from 640 to 2 kilo, but mean was 1 kilo babies. So there are centers that are trying to start using TCPC now. Okay, so that's all the data. I showed you randomized controlled trials. I showed you different drugs. I showed you the data from PDA Tolerate trial where they're trying to treat at 7 days of age. I showed you some data about transcatheter PDA closure. So if you decide to treat, how do you define PDA management in micropreemies? This is from University of Iowa. Patrick McNamara now works. He's done a lot of work on PDA, a lot of work on neonatal hemodynamics, one of the leading authorities in this field. So this is their recommendation. This is what they do. Small PDA or a low volume shunt, they just repeat the echo as needed. They do echoes very often. Follow-up echo every 1 to 2 days until pulmonary vascular resistance normalizes or after nitric oxide treatment for hypoxemic respiratory failure. So they typically get an echo at 18 to 36 hours of age in their babies. And there is a significant PDA defined as ductal diameter more than 1.5 or LA aortic ratio more than 1.5. They also use other parameters, but just remember this 1.5 and 1.5 appears to be a standard number. If there is a moderate large PDA and a high volume shunt based on the left ventricular outflow or flow reversal, then they will start with Tylenol, 15 milligrams per kilo IV or paracetamol, Q6 hours for 12 to 16 doses, so 3 to 4 days. Then they repeat the echo within 12 hours of after at least 12 doses of Tylenol. And this Tylenol, their intention is not to completely close the duct, but they want to make the ductal diameter smaller, decrease the shunt less, so that the babies don't develop pulmonary overcirculation and pulmonary hypertension, increased need for respiratory support. If there is cardiac dysfunction, left ventricular volume overload or right ventricular dysfunction, they will start dobutamine anywhere from 2.10 mg per kilo per minute at their first line, and then they use alternate drugs. So this is what they manage, the micropremies with the ductus arteriosus. So they also have, because they have lots of 22, 23, and 24 weekers with excellent outcomes by both Patrick and Dr. Jonathan Klein et al. From this unit in Iowa. So in babies less than or equal to 26 week gestation, we're talking about 22, 23, 24, 25 weekers. They exclude the fetal diagnosis of congenital heart disease. They get an echo, as mentioned. So again, observe or use Tylenol, use dobutamine, and then if the baby with congenital heart disease, they refer to pediatric cardiology. Here's another proposed guideline or algorithm or care map, whatever you want to call it. This was published in November in Pediatrics by a group in Atlanta, Dr. Hamrick et al. You can see this is less than 24 hours, 2 to 5 days, and then after 6 days or so. So consider early targeted hemodynamically significant prophylaxis with indomethacin, that is less than 24 hours in some selected babies. If your spontaneous closure rate is high in your NICU, look at your data, you have a lot of babies that close spontaneously, then don't treat it. Okay, no prophylaxis because it's not been effective. And then they go in the next 2 to 5 days. The treatment was effective, not effective still, then do an echocardiography and the baby is hemodynamically significant PDA, then consider treatment of symptomatic, that is a nasal cannula more than 2 liters, FiO2 more than 0.5. They treat with ibuprofen after 6 days postnatally. Otherwise, the baby has not a hemodynamically significant PDA, no clinical symptoms, you just watch. So again, after 6 days, you reassess, do an echocardiogram, consider repeat the treatment. It's effective, done. If not effective, then only they will consider definite ductal closure, either by catheter intervention or surgical ligation if baby has persistently hemodynamically significant PDA and symptomatic over time. Again, rescue treatment, they recommend paracetamol. So where do we go? Again, there's a new trial called Pivotal trial, which stands for Percutaneous Intervention versus Observational Trial of Arterial Ductus in Low Birth Weight Infants. Only 20 babies are going to be enrolled. This is transcatheter closure. So because of the COVID pandemic, the study completion date is extended to December of this year. We'll wait for the results. Again, primary outcome is need for respiratory support or supplemental oxygen until 1 month post-intervention. So where do we go? We do need a randomized controlled trial comparing truly conservative treatment versus transcatheter patent ductus closure. Because when you do TCPC, the duct is completely closed. No question about any residual shunt, right? It doesn't reopen. That's the study we really need to see if treatment makes a difference in the long-term outcome. Whom to treat? I think babies less than 27 weeks or less than 750 grams are the ones that have a significant problems with a huge shunt. When do we intervene? We shouldn't treat in the first day or second day or third day, preferably around 7 to 14 days of age, as was done in the Tolerate trial. Early targeted treatment rather than exposing lots of babies to treatment. Since failure rates with drugs is high and surgical ligation results in more morbidities, TCPC, which is a definitive treatment, is likely to become the standard of care in the next 5 years or so. The only limitation is availability of interventional cardiologists, anesthesiologists. And at the present time, many centers move the baby to a catheterization lab, but there are some centers now doing TCPC in the NICU without moving the baby to an operating room with a C-arm for fluoroscopy. Again, one size doesn't fit all. Treat all PDAs versus don't treat any PDAs should be abandoned. We shouldn't have that approach. We should treat selective, targeted treatment of babies with hemodynamically significant PDA and clinical symptoms like metabolic acidosis, decreased systemic perfusion in the middle cerebral artery or renal artery or mesenteric artery, you should target treatment on those babies. Thank you very much.
Hello, my name is Adriana. I'm head of the Department of Neonatology, University Emergency Hospital, Bucharest, and I will present you a difficult case we faced a few years ago, intrauterine hemorrhagic stroke, postnatal outcomes. It's about a premature 32 weeks gestation baby coming from a mother with severe immune corticoresistant thrombocytopenia. Prenatal ultrasound showed the presence of a cerebral hemorrhage in fetus. Postnatally, the baby received Apgar score 4, needed resuscitation, developed RDS, moderate neurologic impairment, had severe and lasting thrombocytopenia requiring substitution treatment and IV immunoglobulins and corticotherapy. A cranial ultrasound and CT revealed a large hemorrhagic cyst in the right paraventricular region communicating with lateral ventricle, intraventricular hemorrhage, mild asymmetric hydrocephalus. Cardiac ultrasound showed also alterations, severe ventricular hypertrophy, left outflow tract obstruction, mitral insufficiency, and ejection fraction of 50%. Enterally fed from 24 hours of life with mother's milk, the baby had slow weight gain, therefore he was switched on formula. Despite multiple referrals and interventions, the case had an unfavorable clinical course with long-term mechanical ventilation and neurological impairment. Mother was 35 years old, first baby born alive. He had a previous lost pregnancy. She had severe immune corticoresistant thrombocytopenia. She had been advised against becoming pregnant. She had poor compliance to treatment and investigation during this pregnancy. She was diagnosed at 32 weeks gestation with this large periventricular cyst in baby's brain, which led to decision for emergency C-section after correction of maternal thrombocytopenia. The baby was hypoxic at birth, had cutaneous hemorrhagic manifestation, was slightly jaundiced, developed RDS and was on mechanical ventilation, had cardiac murmur from birth, and general hypotonia. Labs show severe thrombocytopenia treated with transfusion, immunoglobulin, and corticotherapy. Cranial ultrasound and CT revealed a large hemorrhagic cyst, 48-30 millimeters in the right paraventricular region, communicating with lateral ventricle, blood in the lateral ventricles, and mild asymmetric hydrocephalus. The case was referred to neurology, neurosurgery, cardiology, hematology. All recommendations were to make serial ultrasound and evaluate the baby for cranial hypertension, otherwise only supportive therapy. Clinical course was altered by frequent pulmonary hemorrhage and progressive hydrocephalus. From investigation, we noted a severe and recurrent thrombocytopenia and anemia, positive inflammatory response after 40 days of life, negative cultures except ET tube culture positive for Klebsiella after 1 month of life, raised unconjugated bilirubin levels, hypoglycemia and hyperproteinemia in CSF, and imagistic exams showed, as I mentioned, a large hemorrhagic cyst in the right paraventricular region and a severe biventricular hypertrophy. We could not measure the level of maternal antibodies, and the metabolic tests were not available up to the moment of transfer in the other clinic. These are images with our baby's brain at birth and his heart, who was examined at 1 month of life. And the graphics show the variation of number of platelets during the first 55 days of life. The interventions and treatment was multiple. The baby was hospitalized 2 months in our clinic, continuously respiratory support, initially nasal CPAP, 72 hours of life, then alternatively mechanical ventilation and nasal CPAP. We actually couldn't wean the baby from from the devices, respiratory devices, administered the inhaled nitric oxide, antibiotics for prevention and treatment of pulmonary associated pneumonia associated ventilation, transfusion with fresh frozen plasma, thrombocytes, and red pack cells, intravenous corticotherapy and immunoglobulin, metoprolol beta blocker, diuretics, TPN, sedation, serial ventricular tapping. The baby was breastfed, as I said, mother's milk, expressed mother milk from 24 hours of life, and switched on formula in the second month of life. What went well? Of course, survival of this very affected baby, a relative control of bleeding. The baby didn't develop seizures, although the cerebral structure was altered. Cardiac function improved with treatment. Obstruction of the left outflow was reduced. He had good feeding intolerance and somatic growth. We didn't get CNS infection, and hydrocephalus was stabilized without shunting. What we could have done better, maybe a sooner antenatal diagnostic, better intervention to pregnancy, and maybe earlier extraction of the fetus would have be beneficial. Postnatally, we are thinking that maybe sooner cardiac examination would have been counted. Better ways of ventilation and better platelet substitution would have lead to a better outcome. And using formula and not mother milk from the beginning would have shortened the duration of the thrombocytopenia. I would like to launch some discussion point for the audience. If any intervention during the pregnancy could really change the outcome of this baby, then regarding the gestational age, a term baby would have been as much affected as a preemie, or earlier extraction would have prevented the cerebral damage. Then cardiac condition, was it congenital metabolic, or it was determined by long ventilatory strategies? Why couldn't we wean the baby sooner? Because the cardiac or cerebral condition, or only the repeated pulmonary hemorrhages? In the case of history of prenatal hemorrhagic event, what is the level of thrombocytopenia that should be corrected through transfusion? Then I would like to ask if, considering the history, what would have been the expected duration for maternal antibodies to be metabolized and the frequency for substitution therapy? And at last but not the least important for us, is breastfeeding a contraindication in immune thrombocytopenia? Thank you very much for your attention.
Hello everybody, I just want to thank the organizers of the forum for this very intense program and for this opportunity to talk and share our experience. The topic is total hypothermia in treatment of asphyxia in newborn babies, experience of the Kyiv Perinatal Center. The presentation analyzes the therapeutic hypothermia as the most effective method to treat asphyxia in newborn. Hypoxia is a universal factor of brain injury. The asphyxia of newborns is a continuation of intrauteral hypoxia and is a reason of a perinatal mortality, 20 to 50%, stillbirth, 59%, and intranatal and early neonatal death, 72.4%. The key investigation, interventions and treatment is therapeutic hypothermia. The baby was transferred to a pediatric hospital on the 46th day of life for more detailed examination and rehabilitation. The girl was born, this was first pregnancy, first childbirth, it was C-section through the lack of movement of fetus during the 2 days of meconial amniotic fluid. There was no movement of the fetus, and there was emergency C-section due to fetal distress and meconium. That was 39th week, and the girl was born 2,900 grams, length of body 59 centimeters, Apgar 2-3. The condition of the baby was really severe. That was cardiorespiratory depression due to labor asphyxia. So resuscitation was done, and on the 15th minute of birth, the baby was transferred to intensive treatment unit. And the results here, the pH of umbilical 7.8, so the B is minus 16.3 millimole per liter. Also hypocalcemia, hyponatremia, hypocapnia, and hypoglycemia. Also anemia, hemoglobin was 39 gram per liter and hematocrit 12.5. Instrumental methods of investigation on the amplitude integrated encephalogram, pathological pattern bioelectrical activity of the brain, results of NSG, the cerebral edema, then ventricular dilatation, heart ultrasound, foramen ovale, patent foramen ovale, high pulmonary hypertension, ultrasound of abdominal, ultrasound, hepatomegaly, ascites, ischemical nephropathy. Also the neurologist examined, there was cerebral coma and seizures, and also ophthalmologist had looked at that, was examined interventions and treatment. So venous umbilical catheter was installed for central venous access. Mechanical ventilation was the traditional conventional ventilation, and then high frequency was administered, and then parenteral nutrition was started, 100 milliliters per kilogram, that was glucose, calcium gluconate, electrolytes depending on the daily need. Also take into account the anemia, blood transfusion was erythrocyte, 15 milliliters per kilogram. That was group 2 positive, A2 positive 5 hours after stabilization. We started the active cooling, Tecaterm Neo with the active cooling 72 hours and rewarming 12 hours. Anticonvulsants were given. Diazepam 0.1.3 milligram per kilogram. Analgesia and sedation were done with morphine hydrochloride, starting 50 microgram per kilogram during 30 minutes, and then 10 to 40 microgram per kilogram supporting treatment, and then stabilizing hemodynamics. That was done dopamine or dobutamine. Also antibacterials were administered. Benzyl penicillin and gentamicin were administered. During all the treatment hypothermia, the conditions of the baby remained severe. There was seizure syndrome, and there was tonic tension. Also EEG demonstrated that there was oliguria and edemas. And what went well? There was a severe hypoxic ischemic encephalopathy at birth. All the treatment hypothermia was done with thermal with servo control, with the support of rectal temperature from 33.5 to 34 degrees Celsius, and the first 6 hours it was started. And then the indications were distress of the fetus, pH of umbilical blood, cord blood, and also more than 10 minutes of mechanical ventilation, as well as clinical hypoxic ischemic encephalopathy and anomalous data on EEG. So in our case, we managed to stabilize the condition after 5 hours after birth, and so the treatment hypothermia was started on time. The baby was examined by the neurologist, cardiologist, and ophthalmologist, and the EEG monitoring was ongoing, and sedation and analgesia were done continuously while the baby was in hospital at the age of 21 days. Some movements in hands and reaction to examination, eye opening started, and the increase of motor activities up to 25th day of life. On the 25th day of life, there was a weak suckling reflexes. The baby was extubated, spontaneously breathing, and was transferred to post-intensive care to be together with the mother. At the age of 1.5 months, the baby was transferred to a pediatric hospital. and then was referred to the follow-up center with babies with organic injury to the nervous system for the early rehabilitation. The peculiarity here for this clinical case was the situation that in 2 hours after the completion of the rewarming, there was pulmonary bleeding recorded. The baby received hemostatics. The frozen plasma transfusion was done, 15 milliliters per kilogram, vitamin K and hemostatics. The pulmonary bleeding during the rewarm was the cause to increase the rewarm phase by 6 hours. So our rewarm phase actually lasted 18 hours. After this case, we had more than 10 cases after of the treatment hypothermia with warming up phase of 18 hours, and we noted the lack of negative consequences or hemostatic disorders in these babies. We also would be interested to hear your experience. Was our decision rational? Would you make the rewarm phase longer to 18 hours? In what kinds of cases would you stop hypothermia? What drugs did you use during hypothermia? We would be grateful for the feedback. Thank you very much for your attention.
Good afternoon. I'm going to be talking about the management of high-risk pregnancy from the perspective of obstetrics or maternal fetal medicine, and then Dr. Kramer will talk about the neonatology perspective. Although I'm going to be talking a lot about the management of the mother, I'm going to be emphasizing the collaboration that's necessary between the obstetrician and the neonatologist. I have no conflicts of interest regarding this presentation. I'd like to start off with a case that we had recently at my hospital, a 29-year-old gravida 1, para 0 at 22 weeks and 5 days, presented with a history of no previous pregnancy complications, but she had spontaneously ruptured membranes 2 hours prior to arrival. At that time, her cervix was closed. She was not having contractions. There was no bleeding. We confirmed that membranes were indeed ruptured based on physical exam, plus the ultrasound finding of low amniotic fluid volume. Fetal size was appropriate for weight. It was found for dates, and it was found to be a female encephalic presentation. The neonatology consultation was performed to discuss issues of periviability, potential for survival, potential for intact survival without long-term complications, etc. And the couple decided that they didn't want resuscitation or aggressive life-saving maneuvers until the infant was at least 24 weeks if it was born at a later gestational age. So in the meantime, they just said, just comfort care only. So the maternal fetal medicine doc counseled the patient at that time, and she said, well, she did want to have fetal heart rate monitoring in case there was evidence of fetal compromise, and then she would want to have a cesarean for fetal indications. And she also requested that betamethasone be given for fetal lung maturity. Well, this created quite a conflict because the neonatal request, which was comfort care only, basically treat the pregnancy as non-viable, seemed to be a contradiction to the request for maternal management, in which case she wanted to have somewhat aggressive interventions. And that conflict got everybody upset because there needed to be more consultations and more follow-up, and the nurses didn't know what to do, et cetera, et cetera. And this brings up what I call the decision matrix here, that the care of the newborn and the care of the mother aren't always in agreement with each other. So simplifying things greatly and summarizing them in a simple dichotomy, the neonatal request is either to do life support or not do life support, comfort care only. And the maternal request is whether or not we should be aggressive and do a C-section if needed for fetal indications or no C-section. And most of the time, these are in agreement. Most parents that say they don't want life support and they want comfort care only also say they want no C-section because they consider the pregnancy pre-viable. Or if they decided they want life support, then they want aggressive intervention, do everything possible and the care of the mother. But sometimes they appear to be in conflict. And in this case, for example, the mother decided that she wanted to have a C-section, betamethasone, fetal monitoring, all of this, even though she didn't want aggressive resuscitation of the newborn, because her goal was to just maximize the probability that she delivered a live-born infant so that she could say goodbye, recognizing that the baby was almost certainly going to die, but she wanted the baby to be born alive. And that's a reasonable parental request. On the other hand, some mothers would say, even though they've said they want the baby to have life support, they don't want to have a C-section, recognizing the great increase in maternal morbidity that occurs with a very early preterm C-section. And so these appear to be in conflict, but the reality is there are rational reasons why a mother may choose both of them. And the way to get harmonization about those rational reasons is to make sure that the parents, the newborn, the parents, the neonatologist, the obstetrician, the nurses, everybody is all in communication. So the parents get their information from one doctor, another parent may hear and may not be present when that doctor is there, and then they transmit that information to their parents and the other family members, and then the nurses are involved at some level, et cetera, et cetera. And the main thing is just to keep the lines of communication open so that everybody's clear about what the parents want and why they want it. So there are many situations besides periviable preterm birth that demand this kind of collaboration and coordination. So periviability are the ones that we see most often that are very challenging in terms of understanding the parents' wishes and making sure they have all the information to make a rational choice. But really, any preterm birth involves some collaboration between the obstetrician and the neonatologist. When we diagnose fetal anomalies, be they lethal or non-lethal, we'll oftentimes have the neonatologist involved in counseling the parents about what to expect after the baby's born. And even though we as obstetricians may say this anomaly is uniformly lethal, we have to recognize that it may not be lethal in utero and the baby may well be born alive, and there may be some need for neonatal care and some clear understanding about how much neonatal intervention to do. We also expect that there should be some collaboration for not just C-section deliveries where we require somebody from the intensive care nursery to be present, but really for every delivery that the newborn care team needs to be aware of what's going on with the mother and whether there were medical complications, medications, et cetera. And then finally, there's obviously some collaboration needed when we transport a mom from one baby to another. So I'm going to show you how we solve some of these communication and collaboration issues in my practice. And to really put it into context, you have to understand something about my practice. I'm a maternal fetal medicine specialist. I practice in a private office, which is located in San Jose, California, which is part of the San Francisco Bay Area. It's a metropolitan area of about 8 million people. It comprises several cities that you may have heard of: San Francisco, Oakland, San Jose. Less well known, San Jose is called the heart of Silicon Valley. It's a big technology center. And my office is a freestanding office, which is located about 5 kilometers from our delivery hospital, which is where our neonatologists are noted. We have located the office away from the hospital because we want to be somewhat central to several referring hospitals where we get patients from all over the Bay Area, including 3 referring hospitals that are located in relatively rural areas, anywhere from 40 to 100 kilometers away. So we accept referrals from all these different places for outpatient consultation, ultrasound, and for maternal transport. When we need neonatology subspecialists, we have some subspecialists. We have a surgeon team that practices at our local hospital. They are based out of Stanford University, which is about 40 kilometers away from our main hospital. But these surgeons do come and do perform neonatal surgery at our hospital. We also have several surgical subspecialists that are based out of Stanford who practice in the community, but don't necessarily practice at the hospital. And also when we need cardiology and the babies that have cardiac surgical needs, we transfer those moms to deliver at the Stanford Hospital. And when we have twin-to-twin transfusion issues or other situations requiring fetal surgery, we send those to UC San Francisco, which is about 100 kilometers away. So this is our area, our catchment area, and this is the part of the genesis of why we've solved the problems the way we have. So the first issue is pre-delivery consultation, when we identify a mom who's going to deliver a baby who needs special care. And this could involve lethal anomalies or syndromes that we diagnose, where we want to have a neonatologist talk to the patient beforehand, before she delivers. So we used to have the neonatologist come to our office to do these consultations, but as you know, neonatologists oftentimes, well, they're hospital-based and they are out of their element when they have to leave the hospital. And sometimes it's very difficult for them to coordinate time away because they can't be too far away from the nursery. So then for a while, we had the patients go to the hospital and have their consultation at the hospital, which was more convenient for the neonatologist. And of course, during COVID, all of this went virtual, and we do these consultations now via telemedicine. So it's more convenient for both the patient and the neonatologist. When we need to have pediatric cardiology involved, when we, for example, diagnose a cardiovascular anomaly, we will refer that patient to the Stanford University Hospital, where they have a cardiovascular team and they can do cardiovascular surgery. And then generally they will have a fetal echocardiogram there, even though they've already had one in our office. When we need pediatric surgical subspecialists, for example, ultrasound identifying abdominal wall defects, CPAMs, or conjoined twins, we refer that to the general surgical team. Most of these cases can have surgery at our local hospital, but the conjoined twins are done in Stanford if we have those. The patient wants to continue the pregnancy. For urologic consultation, we do outpatient consultation. The urology team has offices both at Stanford University, but also in our local area in San Jose. And so these consultations can be done wherever it's most convenient for the patient. And we'll generally take CD images of the ultrasound findings and send the patient with a CD in her hand so the urologist can see our ultrasound images. For facial clefts, club feet, a variety of other surgical problems that require a surgical subspecialist, will send to the local specialist practitioners for a consultation regarding that. And generally they will just have a copy of our ultrasound report in hand. So that's the overall approach to outpatient pre-delivery consultation. We also keep a list of patients who are likely to need inpatient NICU care at the time that they deliver. And we have twice a month a multidisciplinary team conference involving the OB specialists, the neonatologists, including the surgeons and other specialists as needed. Nurses and social work attend. And we at this conference discuss all the antepartum inpatients who will likely need delivery soon, and any outpatients that we think are going to need admission to the NICU at our hospital. Generally, this is anomalies and also patients with threatened preterm birth. And this happens twice a month. So another special situation is maternal transport. And here the communication issue isn't so much between OB and neonatology as it is between OB and OB. And the Society for Maternal Fetal Medicine and the Patient Safety Committee, for which I'm a member right now, recently developed and published last year what we call the briefing form and checklist, which is a communication document that's designed to make sure that all kinds of things that we need to discuss between the sending hospital and the receiving hospital, to just make sure that everybody's on the same page with all kinds of things like who are the primary doctors involved, what's the dating information, what's the ultrasound presentation, fetal heart rate monitoring, meds that have been given, et cetera, et cetera. And this we think is an important communication tool that is generated at the sending hospital, but goes with the patient to the receiving hospital to make sure that all the I's are dotted and T's are crossed. It's kind of a patient safety checklist. Once the patient gets to our hospital, very often she needs to have a neonatology consultation as an inpatient. Common situations where we will request neonatology consultation include periviability issues as well as anticipated admission to the NICU. So the information that we want the neonatologist to give our patient and the family is the survival statistics, as well as statistics regarding the rates of serious complications, as well as just to give the family an overview of what to expect if the baby is delivered and needs to go to the NICU. What's it like in the NICU? What are we going to do to the baby? What kinds of treatments are likely to be needed? If it's possible and the patient's mobile enough, sometimes we'll have one of the nursing team or one of the social workers actually take the patient to the NICU and do a brief tour so they can just kind of be familiar with where it is, as well as what kinds of things to expect and what things look like there. And we also then want, in special situations like the periviable situation, we want to know what's the patient's decisions regarding things like intubation, life support, vigorous resuscitation, et cetera, versus comfort care. And with those decisions, that helps us to guide our decisions about cesarean delivery, fetal heart rate monitoring, and the timing of steroids, especially in the periviable situation. So for the rest of the talk, I'm going to talk mostly about maternal management, and not so much in consultation with the neonatologist, but just the kinds of things that we do and why we do it. And in the USA, a lot of our management is driven by this consensus document, which was revised by the American College of OBGYN and the Society for Maternal Fetal Medicine in 2017. And notice when we talk about collaboration and coordination between the obstetrical care and the neonatal care, notice that the American Academy of Pediatrics or any sort of neonatology group isn't included in this care consensus because for the most part, the care consensus involves interventions that we do for the mother: antenatal steroids, tocolysis, magnesium, antibiotics, etc. And there's only really one that has to do with neonatal care, which is the assessment for possible intervention. I'm sorry, I clicked my button twice here. And by and large, on this care consensus, it basically treats everybody at 24 weeks and greater as being potentially viable and really a candidate for all of these types of interventions, with the one exception being that cesarean for fetal indications is not really a definite yes. It's just a, should be considered on consultation between the obstetrician and the mother, etc. And pretty much before 23 weeks of gestation, it's no, no, no for all of these interventions. The one exception being that there may be some role for considering resuscitation of babies born at prior to 23 weeks of gestation. And there may be some consideration for antibiotics for ruptured membranes. And we'll talk about all of these different things together. So the consideration about survival and the information that we want to give about survival and long-term complications is basically, oftentimes we will have the neonatologist drive this, this consultation. And our neonatologists for a long time insisted that they didn't want to get calls from general OBGYNs about peri-viability discussions. They really wanted calls from maternal fetal specialists. And the reason is because we understood as the maternal fetal specialists, we do these things more often than general OBGYNs do, what information exactly the neonatologist is looking for. And really to do a good job at the neonatal counseling, the neonatologist needs to have these basic data: gestational age, birth weight, infant sex, singleton, and have steroids been given. And then there's some nuances regarding any comorbid conditions and the reason why delivery is expected, et cetera. And our neonatologists have since acquiesced, as long as they understand that the obstetrician is perfectly capable of giving this information. It's largely based on ultrasound. And the obstetrician is perfectly capable of giving that information, and they're willing to do this as long as the obstetrician actually has that information in hand. The reason why they need those 5 elements of basic information is because they fit into an estimator. It's an online calculator that actually gives them, plugging in those basic data, the gestational age, birth weight, sex, singleton or twins, and antenatal steroids. If they push that into into this calculator, they will, it gives them estimates of survival as well as survival without profound neonatal morbidity, or what's the rates of significant long-term neonatal complications from being born at these various gestational ages. This calculator will work at 23 to 26 weeks of gestation. It's based on Vermont Oxford data. And the question is whether that Vermont Oxford data is helpful to you or useful to you in your practice, because these data vary from site to site and from country to country, as you'll see. So here's some data that comes from 2 different studies. One, Risavi et al., was based on 24 academic centers in the National Institutes of Child Health and Human Development in the USA. And the Mihaela study was based on 65 studies done internationally. And you notice that there's a difference in the time frame. This was a relatively restricted time frame, and this is a much broader time frame that includes all of Risavi's data. But you'll see by the heavy green line up above, that's the Mihaela data, and the heavy blue line, which is the Risavi data. Despite these differences in the methodology, the overall survival statistics are virtually the same in the 2 studies. And you can see that there are some survivors at 22 weeks of gestation, quite a bit more at 23, et cetera, rising to over 80% by 26 weeks. And then unfortunately, we can't harmonize the data about survival without morbidity, because Risavi reported about survival without severe impairment and survival without moderate to severe impairment, whereas Mihaela reported only survival with no impairment. But you can see that these are basically all consistent with each other, and they give you a ballpark idea. So this would imply that if you can do two very different studies with very different populations and get similar results, there shouldn't be that much variation from site to site about these things. But the reality is there's huge variation from site to site. This paper by Helenius summarized studies from 10 different international collaboratives regarding the overall survival statistics. And this is not survival without morbidity. This is just overall survival from 10 different international collaboratives, Japan, Sweden, primarily high resource countries, Spain and Israel, et cetera. And you can see there's huge variation, especially in these very early gestational ages, the 24 and 25 weeks. There's almost a threefold variation between the lowest and the highest at 24 weeks, and almost a twofold variation between the lowest and the highest at 25 weeks. And extrapolating these lines down, which isn't especially legitimate to do, but you can imagine that there's also a huge variation in the 22 and 23 weekers. So it's really important when you're talking about survival data to know what's appropriate to counsel your patients based on your data, and whether that means your center, which is usually not possible because most centers don't have enough numbers to really sort out the differences, but based on your region or your country or something related to specifically to you, because there can be huge variations. So in terms of maternal care, there's all kinds of choices that we have to make, whether to give steroids, should we give tocolysis if the mom's in preterm labor, should we do a C-section if needed for fetal indications, et cetera. And so the next part, we're going to be talking about some of those choices and why we do the things we do. First, antenatal steroids. So this data comes from a meta-analysis, and on several of my subsequent slides, you'll see that there's a significant difference between treatment and non-treatment. I've covered it in red so that it just jumps off the page at you, and you can see this meta-analysis of 27 different randomized trials of steroids says that there's a significant reduction in perinatal death, neonatal death, RDS, necrotizing enterocolitis, interventricular hemorrhage, developmental delay. There's sort of no question that steroids are beneficial when given between 24 weeks all the way up to 36 and 6. So different societies have taken this information different ways. The American College of OBGYN says, well, first of all, there's no randomized trial that included patients less than 24 weeks of gestation. And so they really say that we're really just extrapolating from what we know at 24 and beyond. And they say if the parents have decided that they want resuscitation and that they're considering the pregnancy be viable, it may be reasonable, and you may consider giving antenatal steroids at 23 to 23 and 6. And they say definitely between 24 and 36 weeks, if this is the anticipated date of delivery, that antenatal steroids are recommended. Royal College of Obstetricians has a slightly different take on it, but basically similar. It's at the low end, it's the same. Discuss steroids with women if she's threatening to deliver in that 23-week time frame, and do give steroids to anybody less than 34 weeks of gestation. And they say that at the more advanced gestational ages, just consider antenatal steroids. And it has to do with the Royal College's take on the data from the United States trial of late antenatal steroids. So even though the American College of OBGYN says no steroids prior to 23 weeks and just considered it at 23 weeks, you can see that how many patients actually received antenatal steroids, and this is based again on this NICHD data from Resavi, that the majority, if the parents had elected active treatment, even at 23 weeks, the majority, almost 70%, were getting steroids. And even at 22 weeks of gestation, almost a quarter of them were getting antenatal steroids. And certainly the vast majority by 24 weeks were getting antenatal steroids prior to delivery. And even if the parents had elected no active intervention, they said basically comfort care for the babies, a quarter of the patients were getting steroids in the 23-week gestation age range. So we use steroids fairly aggressively. This is a more recent study from ARA, and compared to Resavi, you can see that in the more recent years, this is a 5-year period after Resavi's study, that we were given steroids over half the time to 22-weekers threatening to deliver, and over 80% of the time to 23-weekers. So we do use steroids aggressively in this periviable window. We don't know for 100% that they're effective. We have observational data like this that we compare survival with steroids to survival without steroids. You can see that there's improved survival in the group that got steroids compared to the without steroid group. We don't know how much of this is confounding by indication. This is not randomized data. This is observational data. And it may well be that the reason why they survived better is because not only were we aggressive with steroids, but we may have been more aggressive with other interventions like C-section or neonatal resuscitation. When you look at survival without major morbidity with steroids versus no steroids, and comparing this observational study, there's virtually no difference here. There's no real evidence that steroids improve that metric, survival without morbidity. I want to talk briefly about tocolysis for preterm labor. This is almost data that's 10 years old, a network meta-analysis that was done by David Haas and his colleagues that showed that from 95 different randomized trials in this network meta-analysis, that they could show that tocolytics, depending on which class of drugs you used, actually did result in a significant increase in the amount of women that delayed delivery by 48 hours. And you would think that that delay in delivery should actually improve neonatal RDS and neonatal mortality, because we've always said that steroids need to be given for 48 hours in advance prior to these deliveries. And that's 48 hours buys you time to get steroids on board. So improving the number of women that can go 2 days should improve these two morbidities. And although there's some small trends in the right direction, none of these reach statistical significance. In other words, although tocolysis may buy you 48 hours, that's good to get the mother transported and may buy you time to get steroids on board. There's no real evidence that it improves neonatal morbidity. When you actually look at the subgroup less than 28 weeks, here's a smaller meta-analysis. Only 3 trials included women less than 28 weeks and only 1,000 women. There was actually no evidence that tocolysis in these very early gestations actually improved the rate of delivery more than 48 hours or 24 hours or 72 hours, and actually was associated with a trend towards increase in perinatal death, which is an interesting finding. Well, why would tocolysis not be effective prior to 28 weeks? Maybe the main reason is that prior to 28 weeks, tocolysis isn't effective, is because in those patients that have preterm labor with intact membranes, when you do amniocentesis on them and look for markers of infection or inflammation, the majority of women in the under 28-week group actually have markers of infection and inflammation, and tocolysis may not be effective in that group, which may explain why tocolysis doesn't work under 28 weeks. Next topic is use of magnesium for neuroprotection. Here, 6 randomized trials found that women that were given magnesium versus no magnesium or a placebo showed that magnesium given 12 to 24 hours prior to delivery reduces the risk of cerebral palsy and moderate to severe cerebral palsy. And this intervention is widely used for moms threatening to deliver prior to 32 weeks. Some places do 34 weeks. Ruptured membranes, should we give antibiotics or not? Here, the data is fairly clear that giving antibiotics to the moms with ruptured membranes improves a variety of neonatal complications, including infection, positive blood culture, ventricular hemorrhage, improves the chances that the mom's going to get 48 hours or 7 days after a membrane rupture, and reduces the rate of maternal chorioamnionitis. So giving antibiotics for ruptured membranes is fairly universal. A more recent network meta-analysis from last year actually asked the question, which antibiotics are best, and compared all kinds of different regimens. The network meta-analysis shows how many trials were done comparing these antibiotics to placebo versus trials that were done comparing one antibiotic regimen to another. And the conclusions were that there was very good evidence that several of these antibiotics were better than placebo for preventing chorioamnionitis, but they couldn't say that any one of them was any better than the others. And in terms of other outcomes like neonatal infections, et cetera, that there was really not good evidence that these were better than placebo or no treatment, but they said that the evidence was of low quality, and so further studies would be needed. So the question is, should you give antibiotics prophylactically to women in preterm labor with intact membranes? And here, when you look at all those same outcomes, there's really no evidence of any neonatal improvement, no improvement in time to delivery, no reduction in adverse neonatal outcomes. But there is a benefit in terms of reducing maternal infection, basically chorioamnionitis. So although it's not widely practiced, the case could be made that there's actually a maternal benefit to giving prophylactic antibiotics. The question is whether that benefit outweighs the risk of antibiotic resistance from poor antibiotic stewardship, et cetera, but the answer to that is still out. Finally, an intervention that we offer to moms threatening to deliver preterm is cesarean delivery, especially if there's an issue with fetal heart rate tracing or because of breech presentation. First thing is, it's very clear that doing a C-section just because the baby's being born preterm. So this is from the NICHD, the United States National Institutes of Health Consortium on Safe Labor, and looking at all births between 24 and 28 weeks of gestation, and comparing the outcomes of attempted vaginal delivery versus planned C-section. There was no significant difference in any of these outcomes. And although there was a trend towards perhaps increased death in the adjusted relative risk of doing a vaginal delivery, there were also unfavorable trends of doing vaginal delivery in terms of several of these neonatal morbidities. So the conclusion here is that C-section is not indicated just because of prematurity, but should be reserved for obstetrical indications like malpresentation or abnormal fetal heart rate tracing. If you look at breech presentation, on the other hand, from the same data set, you can see that there clearly was an increased risk of death with vaginal delivery, adjusted relative risk of 3.0. This is interestingly balanced by decreases in risk of the other morbidities, but clearly mortality is increased by attempting vaginal delivery to a preterm baby in breech presentation. So we generally will say C-section is indicated for that, for breech presentation. We don't take this decision lightly because there's substantial evidence that doing a C-section very early in gestation increases the risk of maternal complications compared to C-sections that we do closer to term. And here, this is a study that Linda Evans and I published almost 30 years ago, looking at the rate of serious maternal morbidities. Basically, it was tripled for to have any one of these morbidities in doing the very early preterm. So that figures into our counseling about the pros and cons of doing a C-section. So that was a study from almost 30 years ago. Here's a more recent meta-analysis just published in the American Journal of OBGYN early this year that looked at the rate of composite adverse outcomes with C-section at various gestational ages. And although this number, they didn't present data for C-sections at terms, you can see that the earlier you do the C-section, the higher the rate of composite adverse outcomes for the mom. So doing a very early preterm C-section is potentially morbid, not only for short-term outcomes, but for long-term outcomes like risks in the next pregnancy. So this study is a population-based study out of Australia, showed an increased risk slightly of preterm birth in a subsequent pregnancy, increased risk of needing a C-section, 36-fold odds ratio in the second pregnancy after you're doing a C-section in the first, increased risk of infection, largely related probably to doing more C-sections, increased risk that the mother would need to be admitted to the ICU, a 6-fold risk of uterine rupture, and a doubling of the risk of hysterectomy. So doing a C-section is not something that we do lightly, and it is associated with both short-term and long-term harms for the mother. The risk of uterine rupture, we always thought, especially with preterm C-sections, was due to the fact that we did classical C-sections. But the reality is, and this study showed that the increase of uterine rupture actually occurs with preterm C-sections here, comparing 20 to 26 weeks versus term C-sections. There's about a 4-fold increased risk of uterine rupture, even if the original C-section was done with a low transverse incision, which is an interesting finding. In any case, that ends my presentation regarding the maternal management, as well as some on the coordination between neonatology and obstetrics. And I'd like to pass the baton now to Dr. Boris Kramer to talk to you from more the neonatology perspective. Thank you so much, and have a good rest of your day.
Hello, ladies and gentlemen. Andrew has beautifully pointed out what are the challenges ahead of us. I want now to add the neonatal perspective and point out why the collaboration between obstetrics and neonatology is for the benefit of everyone. Let us have a look at Leonie. 25 weeks of gestation, birth weight 450 grams. The perfect example of a high-risk pregnancy. When the baby is born, a long journey starts, and their preparation has a role in the outcome and the care postnatally. So if this was a live meeting, we would ask you now, do you have a routine meeting with your obstetricians and neonatologists? And if so, do you look ahead? Which patients were newly identified that will need your joint care? Or do you look back, what went well, what can be done better, just like a debriefing? And if you don't have a standardized meeting, when do you talk to each other? Just if something went really wrong in order to limit the damage? I want to convince you that there are new challenges ahead of perinatal medicine, as Andrew has beautifully pointed out, and that the communication between obstetrics and gynecologists and neonatologists is for the benefit of everyone. And in particular, look at your outcomes together. That will help you to identify how to improve the care. If you take the perspective of the parents, then a long, long journey just starts. They talk to gynecologists, to obstetricians, to neonatologists, to pediatricians. And this is a journey over several years. And if they are, especially given in this period, double-blind information, one says treatment, the other one says no treatment, and this is terrible for the patients. And that is not appropriate given the life-changing situations that they are going through. I know hospitals that manage to have one case manager for parents that present in their prenatal service, and if they have a preterm baby, they are followed by the same case manager for years for their follow-up. That helps the parents to develop a trust and relationship with this social worker and makes sure that there are no surprises and that there's a continuity of care, no information loss. This is the case that Andrew presented you, the perfect example for double-blind. One says one thing, the other consultant says the other thing. How do you solve that in your institution? In my institution, we have the rule that 24/7, the newly admitted woman with such a high-risk pregnancy has the right to be consulted by the maternal fetal medicine specialist and the neonatologist together in one go. So the neonatologist and the fetal medicine specialist talk to each other before they show their faces to the parents. This prevents ambiguity, double-blind situations, and the parents can put all the questions they have, which are not distinguished between our departmental structures, but are mixed and go from one specialty to the other and vice versa, to this attending specialists and consultants. That has been shown to ask some effort on the side of the consultants. However, the parents are much happier and avoid especially such a dreadful double-blind situation. So if the antenatal counseling is being asked, what should the neonatologist do? Take the responsibility for mother and her baby and get the input of the obstetrician. And Drew already pointed out antenatal steroids, magnesium sulfate, antibiotics, delayed cord clamping. We will revisit some of those aspects later. And most importantly, do you need to transfer to another center? Especially this is a point where you can look together at the outcomes. So if you have a lot of transfers within the first 24 hours, then you should ask yourself whether you're doing the best possible job, because those transfers do not help the outcome. So that is an example of the joint quality outcomes. Talk to mother and possible father, explain what kind of care you can offer, tell them about the anticipated outcomes, show them that you have a protocol in place, visualize your information, and use, if necessary, the calculators that are available. And do not miss the opportunity to talk about breastfeeding. And it is clear that this is, again, a team effort. If the mother does not get, after delivery, the support in the obstetric unit, then this will not work. So make sure that you are talking in one voice, that breastfeeding is a good idea. And these cards have been published some 10 years ago. They explain why such a tiny patient has so many cables and tubes around him or her. That is a visualization of percentages. Percentages are not easy. We have learned that now in the corona pandemic. This visualizes the increase in survival with every week. This gives you an idea about the long-term outcome and the morbidity that is associated with it. You can also visualize the diseases like BPD, intraventricular hemorrhage, or here retinopathy of prematurity. This is then up to your group whether you want to use those cards for antenatal counseling or use this at a later time point. And now, if the baby is about to be born and everyone has to get ready, we have checked everything. And we want now to discuss antenatal corticosteroids. Well, most of those preterm births are associated with infectious diseases like chorioamnionitis. We have recently published a meta-analysis when we looked at the association of neonatal sepsis and chorioamnionitis. And here you have any early onset sepsis, and here you have the culture-proven sepsis. And irrespective of what you are looking at, there is a more than 4-fold increase in the risk of neonatal sepsis with chorioamnionitis. So your antenatal history plays into your neonatal care. And what about the different kinds of chorioamnionitis? You can have maternal symptoms, you can have detection of microbes, you can have just histology. To make a long story short, it is always associated with a robust increase in the risk of neonatal sepsis. So it does not matter how you detect chorioamnionitis, it increases your risk of sepsis dramatically. Now, in this context, every now and then the question is raised whether you should give to a mother, even with clinical chorioamnionitis, antenatal steroids or not. When we visited this question and did a meta-analysis, the outcome was clear. Even if the mother has clinical symptoms, the administration of antenatal steroids saves the baby's life, and it has no effect on the early onset sepsis. So the risk of early onset sepsis is independent of the administration of antenatal steroids. And you should always, always give antenatal steroids. And that is a very important message. If there are doubts among your obstetricians, talk to them that there is no reason to withhold antenatal steroids. And there is another aspect. When I started in Maastricht, I was surprised that during the transport, no antenatal steroids were given. Well, it is the decision of the tertiary center to treat this woman with antenatal steroids, but she is at risk to give preterm birth. So we fixed this problem that the decision was taken jointly between the referral hospital and the accepting hospital, so that the time waiting for the ambulance in the ambulance was used for the benefit of the baby, because every hour counts. And you have to look at your transfer system. This is the situation in Ramanathan's hospital in Los Angeles. Well, if you have 16 million people living on a strip of 70 kilometers by 20 kilometers, traffic jams are the rule. And that's the reason why you do only transport by helicopter. This is the situation in New Zealand. This is inside a Learjet when a neonatal team picks up a baby in a rural environment that is several hundred kilometers away. So you have to address these questions according to your local situation. And don't forget, every hour of exposure to antenatal steroids improves the outcome. I borrowed this slide from Andrew, and I have a different interpretation. If you ask the magic, the question is, when do you need the neonatologist? And it doesn't have to be magic. It has to be teamwork. When you go through these aspects repetitively for every patient and get the information right and get it done. Now, one of those points is the delayed cord clamping. And I have borrowed this slide from Andrew as well and labeled it as a take to work message. So my question is, how does it work in your institution? What is your experience with this recommendation? Does every team has the patience to wait 30 or 60 seconds? I consider this as a prime example of collaboration between obstetricians and neonatologists. Why? Not every obstetrician who is doing the emergency C-section at 3 o'clock in the morning is a fetal medicine specialist. There are in my hospital many oncologic gynecologists that cover those shifts as well. And if you talk to them before the procedure, then you wait together for the benefit of the baby by doing nothing. However, this is for some people a big change in their habits. And if you then wait jointly doing nothing for the benefit of the baby, that is a new experience where you really collaborate for the benefit. However, there is one aspect that is sometimes overlooked. Group B streptococci, maternal symptoms. If you do not give antibiotics, look at the baby, at the mother, but also make sure that you have an idea what the microbiological situation is. GBS is very dangerous, especially to preterm babies. This is old data, some 20 years ago. However, the basic problem has not changed. GBS is a killer, especially for preterm babies. So make sure that in your joint approach to manage high-risk pregnancies, you don't miss GBS because it has an impact and it is something you can do about. And this joint approach of obstetrics and gynecology also includes feeding. Don't miss the opportunity to talk about breast milk. These aspects are for the later step. However, the liquid gold of colostrum should be harvested and made available for the preterm baby. And talk to their mothers in time, talk to your nursing staff, make sure that there is one line of communication between obstetrics and neonatology, that colostrum is really important. And how important it is, we learned this from the veterinary medicine. They already know for a long time that a newborn horse, sheep, or cow will die if the mother is not able to provide colostrum. So they have an artificial colostrum with live bacteria that prevents a neck-like symptom in the newborn animal, and they give this routinely. We have just learned this recently, how important colostrum is. And I want to point out that breast milk is underestimated, and that you should carefully take the decision whether you pasteurize it or not. There are some institutions that pasteurize mother's own milk for the fear of cytomegalovirus being transmitted postnatally to a preterm baby. When we did a meta-analysis on looking into the effects of human milk on the development of BPD, we came across two studies that compared the outcome of raw mother's own milk versus pasteurized mother's own milk. So just the pasteurization was different. However, the changes induced with pasteurization on the protein and on the microbiome took away the protective effect on BPD. So just pasteurizing exposed the baby at a higher risk for developing BPD. Please be very careful when you consider to introduce pasteurization of mother's own milk or continue with it. You are taking away one of the big benefits. Antenatal counseling and care. This calculator is very interesting. I usually don't use it for patients. I use it for education and training. If you have a young resident or medical student, and then you go and have a look at the numbers, and then you show them what is the effect of antenatal steroids, they will never forget that. And that will be a momentum in order to make sure that every woman at risk gets her antenatal steroids as soon as possible. So when we now go back to the list of aspects, there is one situation when the cesarean delivery is being scheduled. You are moving with your team to the C-section theater. So make sure that you are aware about the delivery situations, the transport situation, and avoid hypothermia. Why do I point this out? We were asked to use a new standardized C-section operation room where the mother could watch via video how we take care of the baby just side by side. However, that exposed the baby to laminar airflow, and we saw a drop in the admission temperatures in our neonatal intensive care unit. That was nice to detect this in time. However, this whole focus on the mom's possibility to watch that did not help the baby. So we reinstituted our separate room, which was preheated not only to 23, but 25 degrees Celsius, and made sure that the video footage was available to the mother. Make sure that you do not miss any opportunity to avoid heat loss, and make sure that any changes, especially in your facilities, is being checked beforehand and afterwards, whether it is helping you in the way you are intending that. And I want to point out, not only peri-viable birth is a chance to collaborate between obstetrics and gynecology, but even term-born babies. This is a case that we had a term-born baby boy, vaginal birth 3 hours ago, and then he developed convulsions. The blood glucose was not detectable. And the answer was quick. Oh, mom didn't have diabetes, and her hypertension was well controlled with a beta blocker. So we were looking at the side effects of the maternal medication. This is our quality control that we have done over the past years. We tried to identify high-risk treatments of women with diabetes, which are more associated with hypoglycemia in the baby than others. And we try to adjust our protocols to catch those babies in time. In the old days, we had color codes on our paper files for a diabetic mother, for a mother with beta blockers. Now we have this electronically, and that is a big challenge to make sure that this information is not lost. And if you are getting that information reliably, make sure that you are managing those babies with a standardized procedure and protocol. So perinatology is a team sport. Here, this is Leonie, and you see the follow-up, which is a big success, and everyone is happy. However, the mother has pointed out that the journey she went through from all the time has taken a huge toll in her life, and that she was so fed up of having new people and no structure in the communication and in the smoothing between the different departments, that she gave us the advice to really look carefully that this is one journey. And we as obstetricians and neonatologists can make sure that this works here. However, it does not relieve us from the duty to make sure that this is one smooth line so that everyone has the idea that the care for the baby comes out of one hand, one helping hand. Thank you very much for your attention, and I'm looking forward to your questions.
Thank you so much, both Dr. Andrew Combs and Boris Kramer, for some excellent talk about collaborating with maternal and fetal and neonatal units in staff. I have some questions in the chat. One question for Dr. Andrew was, what do you consider as complete course? If the baby, mom got dexamethasone, for example, an hour prior to C-section, does it count, or you have to wait for 6 hours?
Well, for statistical purposes, an incomplete course is anything less than, for dexamethasone, anything less than the 4 doses given. In terms of whether it's physiologically effective, there is some data from the Cochrane meta-analysis that steroids are beneficial even within the first 24 hours. There's some reduction of RDS and some reduction of mortality in the very early gestational ages. But I don't think that it's likely to be effective within an hour. So in terms of the neonatal outcome, I don't think giving a dose immediately prior to C-section is probably beneficial. There's probably some increasing benefit that starts in 6 hours or so, but I don't think anyone really has the exact data to know that. So it depends on why you're asking the question, what is a complete course or an incomplete course? To me, it's for statistical purposes. I know that we had in the United States, one of our accreditation organizations for hospitals had a quality metric that considered any initiation of steroids prior to birth to have met the quality metric. Whether that was physiologic, I think is probably debatable. But people could meet the quality metric by giving a dose of steroids in the operating room just prior to starting a C-section. I don't think that's good clinical care, but it did meet the quality metric.
Are there any absolute contraindications for antenatal corticosteroids? For example, a mom who is a diabetic on insulin or something like that, in your opinion?
So that particular example is not a contraindication. We give antenatal steroids to moms with diabetes all the time. We generally find that we need to greatly increase their insulin dosage, or if they're on oral hypoglycemias, greatly increase their dosage. And as a rough rule of thumb, the increase needs to be about double for the first 48 hours, and then gradually over the next 24 hours decrease back to the pre-existing dose. So we can manage the hyperglycemia that comes from steroids. One contraindication that was an exclusion from many of the early steroid trials was a mom that had latent tuberculosis, because the tubercle was the attempt to wall off the tuberculous infection, and the concern was that the immunosuppressant effect of steroids might lead to a reseeding of tuberculosis. So here, I think the important thing is to try and get latent TB treated so that we don't have to worry about that so much. And as Dr. Kramer so nicely pointed out, that Bean meta-analysis that was in the British Journal of OBGYN, I think it was about 10 years ago, really nicely points out that the presence of either clinical or microscopic chorioamnionitis is not a contraindication to steroids. That steroids are still beneficial even in the face of obvious chorioamnionitis, and that was a very useful contribution from that paper.
Another question from Dr. Catherine Klebramas from Vienna. How about steroids given 2 weeks before? Would you still consider this as complete, or you would repeat a course or a dose?
Again, it depends on why you're asking the question. In one sense, they have received a complete course of steroids. In another sense, that steroids given more than, really, again, the Cochrane meta-analysis says more than 7 days, most of the benefit is gone. There was some observational data that suggested maybe there was some benefit that persisted for 7 to 14 days, but I think in the larger Cochrane meta-analysis, that's really not borne out. So yes, they have received a complete course of steroids in terms of statistical approaches and in terms of keeping track of what your processes are, but in terms of any clinical benefit, there's no benefit. In the US, the American College of OBGYN does recommend a repeat course of steroids if the patient's threatening to deliver within 7 days after they've received a complete course of steroids, more than 2 weeks previously. And that 2-week cutoff was based on the inclusion criteria in the randomized trial that was done by our obstetrics medical group. I was one of the investigators on that trial, and we just used that as an inclusion criterion. And again, the reality is that if most of the benefit of steroids is gone after 1 week, if you have a patient who's still undelivered after a week and still threatening to deliver within the next week, that's in practice, that's how in my practice and in many practices around the US, the repeat course of steroids is given at that time. We generally shy away from more than one repeat course because multiple courses in several trials was associated with neonatal, a decrease in neonatal head circumference, which was a concern that might be an adverse event. So the repeat courses of steroids per the American College of OBGYN guidelines is 1 repeat course only.
Let me go to Boris. Boris, you talked about GBS, but in the US, in preterm babies, early onset sepsis, E. coli is almost 70-75% of the time it's E. coli sepsis, not GBS, like it happens in a term baby. And in many parts of the world, they don't even screen for GBS routinely. So any comment on that, Dr. Kramer? Boris? Maybe you muted. Okay, while waiting to hear from him, there is a question about, term elective C-section antenatal steroids, like the Aztec trial that was published from UK many years ago. Would you recommend steroids for antenatal, for elective cesarean section in a term baby?
So my partners and I have been doing the following the Aztec results, and anytime we're doing a C-section without labor prior to 39 weeks, we are giving antenatal steroids. The American College of OBGYN did not endorse that conclusion, and so most people in the US aren't doing it. And I'm not really quite sure why the American College sort of glossed over those results. It may have had to do with the outcome was really just was the patient admitted to the NICU, and it didn't really have anything to do with any major long-term morbidity. And I think in that Aztecs trial, they didn't look at hypoglycemia, which was the one complication in the United States trial of late preterm antenatal steroids.
Thank you. Boris, did you hear the question? Can't hear you.
I can hear him.
Okay. Oh, okay. That's strange. You can hear him. I can't hear him.
Andrew, can you hear me?
I can still hear you, yes.
Good. Okay. So
No,
it is a
Boris, you can
problem
hear me?
between the East Coast
Yeah.
and
Okay.
California. So Ram,
That's
watch
strange.
out. So that is the result. If you look at data of countries that have not embraced the general screening, like the Netherlands, like the United Kingdom, you will find that GBS is still a big killer among preterm babies. So what the US sees is the result of their general testing. We have published last year a meta-analysis in the British Journal of Obstetrics and Gynecology comparing more than 1 million women with general screening versus risk-based screening. And to make a long story short, the risk-based screening does not work, and it does not even reduce the percentage of women exposed to intrapartum antibiotics. So you do not reduce the burden of disease, and you do not reduce the exposure to antibiotics. So there is no reason and no good data to support this risk-based screening anymore. However, if you introduce this consistently, you will have then a change in the spectrum and also in the antibiotic resistance of the bacteria retrieved in neonatal sepsis in preterm babies.
Okay. What's the optimal time for termination of pregnancy after preterm prom? If the baby is well, I don't know why they would, the fetus is doing well, why would you terminate a pregnancy? Any comments, Dr. Combs?
Yeah, so I assume that by termination of the pregnancy, the question refers to as you get into the late third trimester, you're expectantly managing somebody with preterm prom, and then the question is, how long do you continue the pregnancy? Do you wait for spontaneous labor? Do you induce at 39 weeks, at 36 weeks, 34 weeks? And that, I think that's the question. I think there's the jury is still out on that. In my practice, we have done 34 weeks for almost 2 decades now, and our rationale is really just balancing the risks of mortality. Expectant management of prom is a potentially dangerous situation. The longer that pregnancy remains in utero, there is a risk of chorioamnionitis, and therefore neonatal sepsis and neonatal death from sepsis. There's a risk of abruption, there's a risk of cord prolapse and other cord accidents, any of which can be lethal. And at 34 weeks and beyond, there's the chance of a lethal outcome from delivering is very low. And in our calculus, the risk of perinatal death is lower with delivery at 34 weeks and beyond. The Dutch did a nice randomized trial about 10 years ago, and I don't remember now the cute name of that trial, but it was basically a randomized trial of delivery at 34 versus delivery at 36 with a specific outcome looking at the rate of sepsis. And they did not show a benefit of delivery, but they also didn't show any benefit of further expectant management. And expectant management, as I pointed out, is not only risky, but it's also expensive. So, of course, putting a baby in the nursery at 34 weeks is expensive too. So I think the jury's out. It's probably 34 or 36, maybe somewhere in between. Not likely beneficial to continue expectant management of ruptured membranes beyond 36.
Okay, I have this question for both of you. Given lack of data on use of neuroprotective of magnesium sulfate in 22 weekers, would you consider 22 and 23 weeks? Would you consider magnesium sulfate? Dr. Andrew and then Boris.
Andrew, do you want to go first?
I'm going to put it, the short answer is we do it.
Okay.
If you think about the data for antenatal steroids in this gestational age, it is just extrapolation of the same underlying biology. And the underlying biology for magnesium is the very same in 24 weekers, in 25 weekers. So if you use this data from as an analogy conclusion from the antenatal steroids, then there's no reason not to give magnesium either.
Do you know an estimate of corticosteroid binding receptors at 22 or 23 weeks, either in a sheep model or compared to 24 or 25 week equivalent?
Ooh, now it's getting tricky. The placenta of our favorite perinatal animal model, the sheep, is completely different from the human. The human is characterized by a hemochorial structure, whereas the sheep has a epithelial structure. So a animal model that is closer to the human situation would be monkeys, or it would be rodents. But rodents have a completely different development of the organs. So only it is the monkeys that can give us some guidance in that. And the answer is yes. It replies even at lower gestational ages, this lung maturation, whatever this mechanism is. So there must be steroid receptors that can mediate this effect.
Again, thank you so much. I know we had some technical issues, but after switching to Zoom only platform, things have gone smoother. I sincerely thank the speakers today, as well as the two case reports. We will try to fit in the third case report. Any final comments? We have 3 more minutes. We are running over it, but I thank the attendees for being patient and attending a longer meeting than we had hoped for. But tomorrow we will have a better start. Any final thoughts, Dr. Combs first, and then Dr. Kramer, about collaboration? What else can we do to improve communication between the 2 disciplines?
I think the main thing is just keep the lines of communication open. The Dr. Kramer posed some challenging questions at the beginning, which is, when are you meeting? And when you meet, what do you talk about? Are you only talking about the future, or are you also going over your outcomes? And I think that going over the outcomes, the what went well and what could we do better, is an important part of that meeting. And I think we can always improve on that.
I completely agree. And I summarize it: perinatal medicine is a team sport. Yeah. Play as a team player.
It's a great summary.
Thank you so much again. Have a good day, all of you. Good evening. We'll see you tomorrow. Okay, thanks.
Thanks.
Okay, bye.
Bye.